Hey guys, this is Dr. Mobeen. We are talking about central nervous system, and the lecture today is about the hemisection of the spinal cord. Very important lecture. This is also called Brown-Sequard syndrome. It was the Dr. Sequard who found out or who wrote about this, so that is why it is named that way. Now hemisection, hemi means half. So what does it mean? Look, hemisection can be complete or incomplete. That is the first classification to remember. What does that mean? If I make a spinal cord here, so this is a spinal cord and this is another spinal cord section. Complete hemisection, half section, means one complete side, complete right or complete left or complete anterior or complete posterior, one complete side is sectioned. Incomplete is where the section is not on one side. That is the incomplete. And the funny thing is, in the clinical scenario, you will see incomplete more often than the complete. Then the hemisection can also be right or left, anterior or posterior, or oblique. So the hemisection can be, so this was complete and incomplete, then it can be right side, it can be left side, or it can be oblique, it can be anterior, or it can be posterior. Very simple. So what does that mean? Let me just make that here. Right and left simply means if this is the right side and this is the left side, we have a complete, a hemisection, a clean hemisection of the right side or of the left side. That would be this way. For example, this is a clean left side hemisection, keeping this thing that this is right and this is left, so then this is the left side. Then anterior and posterior. So if I draw that here, of course, if I make the half, hemi means half, so any half lesion. So now this is the half, and the lesion on the anterior will be the anterior hemisection. The lesion on the posterior will be the posterior hemisection. And how about the oblique? Oblique is this, where it is half of the spinal cord gone, half of the section is destroyed, but it is oblique. So it is on the right side or left side, some anterior, some posterior, there is a combination of that. So now you are seeing various kinds of hemisection. Now this also tells you one more thing, and that is, it is not necessary that hemisection is always right or left. It is also not necessary that it is always complete. So in the clinical floors, in the emergency rooms, when the patient would come in with the wounds, with the injuries to the spinal cord, you will usually see that the injury is incomplete, not anterior posterior, not right left, but oblique and somewhat partial. And the other thing is, the reason for the injury you would see would be either a stab wound, someone stabbed someone in the back, or the shot or the bullet wound destroying the section or one section or more sections of the spinal cord. So these are various classifications. Now from the USMLE point of view, they would always be looking for right or left complete clean hemisection. Now that is not possible in clinical scenario. It is okay in the testing, so they can understand what you know about it, but in the clinical scenario that is not the case. So if that is not the case, how do you as a doctor practice this thing? So please remember this. Why do they want to ask you right or left, complete? This is what they would ask, right complete or left complete. Why do they want to ask you? What they are trying to understand is that do you understand correctly the ascending tracts or the sensory? So what is it? What are the symptoms they want to understand? They are testing you for motor symptoms, that do you know that we have corticospinal tract or the descending tracts. Then we have effect of the upper motor neurons and their lesion, lower motor neuron and their lesion. And please remember, I have done lectures on the upper motor neuron lesion and lower motor separately. I have done lecture on the descending tracts and the ascending tracts separately. So I'm not looking to redo those lectures here, just explaining what are the hemisection of the spinal cord, what topics it is covering, what are they testing you in the USMLE, so what are the things to keep in mind. So that is on the motor side, upper motor neurons and the lower motor neuron, same side or the other side. Then on the sensory tracts, they would see two types of sensory tract. Ascending tract, of course, that is the anterolateral, or the tract for pain and temperature, Then is the dorsal column, or the tract for proprioception and the 2-point discrimination and vibration and fine touch and pressure. So that is the anterior and dorsal. Then local tract, or the tract of Lissauer, Lissauer's tract or Lissauer's tract is the local tract. That tract is within the spinal cord. It is a sensory tract. It is made up of the fibers of the ascending and anterolateral system. So we'll talk about that today, the Lissauer's tract. This is why it is called local. It is within the spinal cord. It does not go to the brain, or it does not descend from the brain. So higher centers do not have effect on it. So these are some of the things that you should know. The other thing, in the lower motor neuron, remember the reflexes. What happens to the local reflexes? So these are the kind of things that if you understand them well, then it is okay to understand. You can actually just draw this and tell what will happen in various kind of conditions. I would add one more tract here, and that is an ascending tract, and that is spinocerebellar. This tract is important for the body's position and the proprioception, or the body's tone and posture maintenance. So we should know about that as well, because in the patients with the hemisection of the spinal cord, the ataxia will appear. So ataxia would be because there is a problem with the proprioception and because there is a problem with the spinocerebellar tract. So these two combined cause that. So with that, let's now very quickly see what are the problems that would occur. So I'm going to make a little human over here. Cool. In this body, all right. So this is a human, and we would see what is the effect on this person as a particular segment is, particular spinal segment is destroyed. Now what you have to remember is that as you talk about these tracts, you also talk about what happens on the same side and the other side. For example, if we talk about, let's say, the corticospinal tract, or the tract coming from the cortex to the spinal cord, motor tract, what you will have to tell is that if the injury is on the right side, then what happens to the corticospinal tract on the right side, and what happens to the motor system on the right side or ipsilateral side, and what happens to the motor system on the other side. The other thing that is really important is this. So let's make this. Let's say this is a body. Here is a lesion. So I've cut the body in halves, right and left half, and here is a lesion. Here are the things that you have to talk about. Number one, motor system abnormalities on the same side and the other side. Motor system abnormalities on the same side and other side. Motor system abnormalities at the same segment, above the segment, below the segment. Other side, same segment, above the segment and below the segment. Similarly, sensory abnormalities on the same side at the segment, above the segment, below the segment. Same side above the segment, at the segment, below the segment. If you can define the problems in this structure, you are fine. If you understand it that way, you're fine. So today's lecture is really trying to establish this understanding. Once you understand this, you can actually go through the various type of sections and you can talk about it, that what will happen. So let's start understanding this. The first thing that I would like to understand or convey is the Lissauer's tract. Why is that important? Because in the USMLE, you would see two kinds of questions related to the hemisection of the spinal cord or Brown-Sequard syndrome. One, you would see they are going to test you for the anterolateral system, pain and temperature sensation that becomes abnormal couple of segments below on the contralateral side of the section. So if the section is here, it would not become abnormal on the other side at the same segment and below, it would become abnormal couple of segments below on the other side. So why is that? Why do they ask that question, and what is the anatomical importance? How can we understand that? That is one. Secondly, on the motor side, they're going to try to say that if the section is here, what happens? The lower motor neuron type lesion on the same segment, other side, same segment, then upper motor neuron type lesions, which side, ipsilateral or contralateral side. So if you understand these two concepts, that is really important. Then they would also, so I've seen the questions where they try to ask you if the dorsal column, you understand that that would stay intact. So that is also another thing. So three basic kind of problems. So let's look at them now. So first of all, I'm going to leave that here, we'll keep referencing it. First of all, let's make a spinal segment. So this is a spinal segment, and here we have to establish 2-3 facts, 2-3 things that we need to understand. One is that descending fibers, corticospinal tract comes down. So this is the corticospinal tract. The fibers descend from the cortex to the spinal cord at every segment. Then the fibers relay, and most of the time there are three kinds of relays. Again, I've done the corticospinal tract. There's a separate lecture, please read there. Here, this much is enough to remember that they would relay on the lower motor neurons. So these are upper motor neurons. They would relay on the lower motor neuron, who would then give the axons that are lower motor, and they would be coming out on both sides, lower motor neurons. This was upper motor neuron. So of course, when a spinal section occurs, injury occurs, at the segment you would see that the upper motor and the lower motor both will be gone. But below the segment, of course, this is gone, but the lower segments would have lower motor neuron intact. So the lower motor would be present, upper motor would be broken, so upper motor neuron like lesion would occur. So remember this one setup. The second setup that you must remember is that the dorsal column, the anterolateral system, not the dorsal column, sorry, anterolateral system fibers, when they relay here, the second order neuron, and I'm saying here, I'll explain that in a little bit more detail. The second order neuron of the anterolateral fibers, I'm going to use green, would turn to the other side and pass through the anterior commissure in front of the spinal canal, and then they would go up. What is the significance of this crossover? The significance is going to be very simple. If there is a section on this left side, so let's say this is the left side and this is the right side. If there is a section on the left side, then this crossing over fibers will be destroyed. But the sensation is coming from the right side. So contralateral sensory problem will occur. On the other hand, if you see the descending fibers, the motor fibers, when these are coming down, these fibers are coming down on the same side and got involved in the injury on the same side. So ipsilateral motor problem. Ipsilateral motor problem, contralateral sensory problem. However, the third thing to now remember, and I will make that in, let's make that in green as well. The dorsal column fibers, the fibers come in here and then they go to the dorsal column and then they ascend up on the same side ipsilaterally. So the fibers would come in here, go to the dorsal column and then ascend up ipsilaterally. So now what happens? The dorsal column is responsible for what? Proprioception, pain, why do I say pain and temperature? Proprioception, vibration, fine touch, pressure, 2-point discrimination, stereognosis, sexual feelings. So that is the, not sexual feelings but sexual sensation, that is passed through the dorsal column. So that goes up ipsilaterally, it decussates up in the brainstem. We have done a separate lecture about the dorsal column. So that means when there is a section on the left side, what is getting affected on the same side? The dorsal column is affected on the same side. That means same side proprioception would go away. Same side motor activity would go away. Opposite side pain and temperature would go away. Now the question is what happens at the segment below the segment. So let's look at that. So once we have understood this, now the second concept that we need to understand is the tract of Lissauer, so that we can see that 1 to 2 segment below, what does that mean? So let's draw the tract of Lissauer. So I'm going to make a few segments of spinal cord here. Let's say we have segment here, we have another segment here, and we have one more segment here. Weird segment. Cool. So 1, 2, 3, let's make one more segment here, 4, and one more segment here, 5. Why 5 segments? It is really important to understand the ascending and descending tract, and let's give them a number. Let's say this is T3, T4, then T5, T6, T7. Cool. We are going to make a section of the spinal cord on the right side. So the section is here. Right side of the spinal cord has been severed, destroyed, clean, complete, right side, actually not right side, left side. So let me just write it here, left side section at the level of T5. So let's say now this one is T5. Cool. The question now you have to tell is what happens above the T5 on the same side, at the T5 on the same side, below the T5 on the same side. Then what happens at the T5 at the same opposite side, above, at and below, and what happens to the sensory and the motor and the local tracts. So here is the problem. Let's start with the Lissauer tract. What will happen is it is the anterolateral system will start from T7. The fibers from the T7, actually I have to make T8 as well, but let's say fibers enter here, dorsal column, they ascend up on the same side. Why did I say dorsal column? Anterolateral system. Ascend up on the same side, keep going through 1 or 2 segments up. Then they relay. So they did not relay on the same segment. They went up to 2 segments and then they relayed. So this part of the gray matter in which they travel, the dorsal, the anterolateral system fiber, the pain and temperature sensory fibers, when they come into the spinal cord, they go up to 2 segments above, then they relay. Then the second order neuron, I am going to make that in green, second order neuron would take origin from that dorsal column tract, why dorsal column, dorsal horn, decussate to the other side through the anterior commissure in front of the spinal cord, go to either the anterior side or the lateral side and make the anterolateral system, and then ascend up and keep going up from there. Now this is the T7, 2 segments above it had the second order neuron that decussated and went up. So here what we are talking is the tract of Lissauer. Now let's take the fibers from T6 as well. T6 fibers will come in, ascend up on the same side, 2 segment up. So they would keep going and relay 2 segments above. Then the second order neuron will originate from here, that is the Clark's nucleus or nucleus proprius, any one of these 2 nucleus. This is the gelatinous material that is present in the dorsal horn of the spinal cord, and it is called the tract of Lissauer, and this is made up of these ascending and descending local temperature, pain and temperature fibers. So from here, this second order neuron will go to the opposite side, anterior or lateral, and then go up. Cool. How about T8? If there was a T8 here, let's make that. Let's make a T8 here. How about T8? The fibers for the T8 will also come in here, go up to 2 sections on the same side. So this is 1, this is 2, relay here. Then the second order neuron would pass on the other side, in front in the commissure, anterior commissure, lateral, and then they go up. Cool. This same thing happens on the other side too. The fibers on the T8 from the other side, T8 from the other side will come in, go up to 2 segments, then decussate and then go up. T7, now please remember, these are very, very, very important concepts. This is what is going to get you the marks, plus this is what's going to get you the knowledge in the emergency room. T7 comes in, starts going up to 2 segments. It got here and got cut. So problem, T7 is involved. T6 tried to go up here, got involved. T5, the section itself came in, got cut. T4, the section above, came in, everything good. Make sense? How about T8? T8 would be safe. T8 would be safe. The fibers would go up 2 sections, that is T6, decussate over and go up. So below the 2 segment, there is going to be an interesting situation on both sides. So we'll talk about that. But first, I hope you understand what is tract of Lissauer. Tract of Lissauer is this tract that is here, and this tract is made up of ascending and descending fibers of the anterolateral system, which are carrying pain and temperature, crude touch and firm pressure fibers. These fibers, when they relay a couple of segments above, the new nucleus body or the soma of the new neuron, that would make that gelatinous nucleus proprius or Clark's nucleus, and that is the tract of Lissauer. So now we understand that one. Now let's see the lesion, what happens to the lesion. I'm going to make this here. Let's say the lesion is T, what was the lesion? T5. T5 on the left side. So think about it, anterolateral system, pain and temperature. On the left side, T5, there is a lesion, hemisection, clean, complete. Look at this segments below on the same side, pain and temperature. What happens at the segment to the pain and temperature? The fibers came in, got broken. So at the segment for pain and temperature is gone. But actually, not just gone. Pain and temperature at the segment is exaggerated. Paraesthesia is present. Why? Because the nerve fibers that are here are broken and they are irritating now. there is inflammatory chemicals there, the nerve fibers are getting irritated. So that section, that dermatome would actually be burning for that patient. Severe pain and temperature feeling would appear till those nerve fibers get healed and that feeling would go away. So at the section, exaggerated hyperesthesia would occur. How about below T6? T6 fibers entered here, then were going to go up 2 segments and got involved. We're talking same segment. Very few books talk about it. They were going up and they got involved. So the section, one more section below, that is T6. T6. What will you see on the same side? Ipsilateral T6, pain and temperature, one dermatome below is involved, gone. How about T7? Same problem, same side, T7, pain and temperature. I know this is not anatomically correct, so please don't hold me to that. T7 present here. That the belly button, T10. So T7, fibers came in, went up couple of segments, got stuck here, got burnt here, got damaged here. So T7 is also involved on the same side, pain and temperature is gone. How about T8? Same side. Fibers would go up 2 sections, then cross over to the other side and then go up, they'll be fine. How about T9 on the same side? Fibers would go up 2 sections, cross over to the other side, go up, they'll be fine. So that means after T7 below, on the same side, pain and temperature is fine. At the segment and 2 segments below, pain and temperature is not fine, that is probably gone or hyperesthesia is present. This is why they ask you what happens on the segment 1 or 2 segments below, this is what's happening. Now let's see on the other side. Section is here at the T5, right? This is where the section is. T5 is broken, T5 is broken. Other side, same side at the section, pain and temperature, fibers came in, ascended up 2 segments, went on the other side and went up. Pain and temperature at the segment on the other side, totally fine. 1 segment below, the fiber came in, went on the same side ipsilaterally 2 segments above and then decussated over and went up, totally fine. So the segment, at the segment, fine, pain and temperature. 1 segment below, pain and temperature is fine. How about 1 more segment below? Pain and temperature, once again it went up. When it reached here, T5, it tried to decussate to the other side, it got burnt, it got injured. So now the second segment below, the pain and temperature is gone on the contralateral side. How about the segments below? T8, fibers came up, T6 decussated on the other side, went up, got damaged, and all the fibers below. So 1 to 2 segments below, opposite side, pain and temperature sensation is gone. Why? Because of the tract of Lissauer. Because fibers ascend and descend for 2 segments. So let me do that here. I'm going to say from 2 segments, 2 sections below, on the contralateral side, pain and temperature is gone. Right? Make sense? I hope this is understandable. Now let's talk about the other sensory tract, proprioception, dorsal column, which I've been slipping my tongue on for the whole day today. Now how does the dorsal column work? It's very simple. The fibers come in on the dorsal side, they go to the dorsal column, that is the gracilis and cuneatus columns, they ascend up ipsilaterally. Ipsilaterally is important, and again I've done this lecture before. They ascend up ipsilaterally and then they go and relay into the nucleus, gracilis and cuneatus in the medulla, then they decussate over there and then they go up. So here let's look at the same section, same side. Fibers for the dorsal column, that is proprioception, 2-point discrimination, fine touch, pressure, sexual sensation, vibration. When that would come in, the fibers are burnt here, injured here, right? So dorsal column, same side, at the segment, fine touch, pressure, proprioception, vibration is gone. How about the segment below? The fibers would come in, ascend up ipsilaterally, ascend up ipsilaterally. Fibers would come in into the dorsal horn, then they would move into the dorsal column and go up ipsilaterally, and they will be burnt, they'll be injured. Same thing here. going up, and they will be injured here. So very simply, below, at and below, at and below, at and below the segment, I am just going to make this green, blue thing, at and below the segments, pain, vibration, proprioception, this is the most important thing, proprioception. Proprioception, sense of position. I've done the dorsal column, please see it over there. Sense of position, the knowledge that what is the angle of the joints and what is the tone in the muscles. It is important for me, for example, if I close my eye and touch my nose, how do I know where is my hand and where is my eye, and how do I coordinate all this? That is proprioception. Similarly, why am I standing, why I'm keeping a balance, that is proprioception. Spinocerebellar tract is also involved in the similar thing. So proprioception is gone. That means the person would become a little wobbly, would not know on the same side the position of the body parts, body muscles and joints. Proprioception, vibration is gone. This is also dorsal tract. Fine touch is gone. That is also dorsal tract. Pressure is gone. That is also dorsal tract. Sexual sensation is gone. That is also dorsal tract. So these are all gone. Same side. Opposite side they're fine, because that is ipsilateral tract goes up on this side, no problem. Cool. So sensory, anterolateral system, dorsal system, we are now covered there. Let's talk about the motor system. Motor system. Now what you have to keep in mind is the upper motor neuron and lower motor neuron. So look, very simple, motor system is very simple. What happens, corticospinal tract comes from the cortex, passes through the corona radiata, then the internal capsule, then it passes through the midbrain, pons, reaches the medulla, makes the pyramid there, and then decussates to the other side, and then starts going down. So in the spinal cord, if there is an injury on the left side, then the left side corticospinal tract would be injured. So let's see what happens here. Excuse me. So this is the lower motor neuron, right? And this lower motor neuron at the T5 has become destroyed. So at the T5, at the section motor system, at the section, so that was sensory, motor system, at the section lower motor neuron lesion on the same side, ipsilateral. So this is ipsilateral, same side, and this is contralateral or the other side. So same side lower motor neuron lesion. Why? Because the lower motor neuron is gone. Similarly, the upper motor neuron that was coming down, the corticospinal tract that was coming down, that tract got damaged here. Below that it is going, but remember this tract, while it is going down, the connection at this from higher center is gone. So at the same side on at the section, lower motor neuron lesion would appear. So this would be lower motor neuron lesion at the section on the same side, ipsilateral. How about below? How about below? This is really important. This is what they're going to test you. Below the lower motor neuron at T6, is this neuron intact or is it destroyed? It is intact. All the neurons below are intact. So lower motor neurons are fine. How about the upper motor neuron? Corticospinal tract is cut here. So do you think that the lower motors now would receive the upper motors? No. Upper motor corticospinal tract is gone. Upper motor neuron is gone. So that means below the section, at the section lower motor, below the section same side, ipsilateral, upper motor neuron lesion. What is the difference between them? I have done that before. The lower motor neuron is flaccid paralysis, muscle becomes very soft, atonia occurs or dystonia occurs, paralysis occurs, muscle cannot move. There are random fasciculations and fibrillation because of spontaneous depolarization and chemical imbalances occurring in the muscle. So the muscle is actually, local reflexes are gone. what happens here is the local reflex. So let's say the sensory input comes in, then the reflex complete, this local reflex is gone, so reflex is gone, but in the upper motor neuron lesion, what happens? Upper motor is not coming in. Upper motor does two: voluntary movements, suppression of sensations, suppression of the local reflexes. These are the three functions it does. Now upper motor neuron is gone, so what would happen? The sensory input would cause exaggerated response in the muscle, so muscle tone would increase. That is a reflex tone. So spastic means rigid, spastic paralysis would occur. Here was flaccid paralysis at the section. So below the section would be the upper motor neuron lesion. Spastic paralysis would occur. Exaggerated reflexes, you do the biceps and there is a big response. Exaggerated reflexes or hyperreflexia occurs. You do Babinski sign and it is positive because this is upper motor neuron lesion. Fasciculation is absent, fibrillation is absent. This is the upper motor neuron lesion. So below the segment, what you'll see is upper motor neuron lesion. How about on the other side? Everything is fine. Everything is fine. That's it. Corticospinal tract is coming down. Come down, giving fibers at every level to the anterior motor, lower motors. That is fine. At the segment, there might be a cross reflexes. For example, if there is pain stimulus on this side, then there is a withdrawal of this and extension of the other side. Such cross reflexes might actually be affected. But that's what we have. One more thing on the passing, we are closing now. The anterolateral system, pain and temperature, is also called affective sensation. Affective, not effective, but affective with A. Affective sensation. What that means is that any time anterolateral tract is triggered and send a sensation, we want to respond. If it is a itch that comes through it, we try to scratch it. If it is pain, we try to withdraw it or push that away. That is not the case with the vibration or proprioception or other. We don't do anything. I know right now what is my body state because the proprioception is happening, but I'm not trying to respond to it and say, okay, I know where is which joint. So just remember that anterolateral system is affected. Final thing now here, spinocerebellar tract. Now spinocerebellar tract, there is an anterior and there is a posterior spinocerebellar tract. So this is the spinocerebellar tract. What is it doing? Spinocerebellar, bringing the posture information to the cerebellum. Cerebellum is responsible for a couple of things. One is it is responsible for planning the movements. For example, when I say, here is my nose and here's my hand and want to touch it, this plan came from the cerebellum. When cerebellum is damaged, there is a thing called dysdiadochokinesia. What is that? Decomposition of the movement. The person doesn't know where the hand is and where the nose is, so it's going to look at the hand and bring it to a position where it sees it and then goes to the nose. This is called decomposition of the movement or dysdiadochokinesia. So cerebellum is responsible for planning, number one, and number two, tone maintenance. Right now I'm standing here. Why am I not crumbling? I'm not crumbling because cerebellum is maintaining the tone. That tone maintenance needs the position sensation and proprioception sensation and the tone sensation. So spinocerebellar tract brings in that information back to the cerebellum. So when that tract is cut, the patient would develop ataxia because of the damage to the spinocerebellar on the same side. So cool, I think that is it. Thank you very much.